When a flood sweeps through a community, what actually happens to public health? It sounds pretty straightforward, maybe.
Yeah.
Just dry everything out and move on.
Right. Seems simple on the surface.
But the reality, as we're about to unpack, is just incredibly intricate. It's this multi-layered challenge that goes way beyond, the visible destruction.
Absolutely. Far beyond.
So today we're doing a deep dive into communicable disease preparedness, specifically for flood disasters. And it's not just about cleanup. It's like a full spectrum phased battle against these hidden, constantly shifting threats.
That's a good way to put it. Shifting threats.
Our mission here is really to unpack a comprehensive plan. How do you prevent and control the diseases that typically pop up with floods? Looking at what happens before the water even rises, during all that immediate chaos, and then critically long after the waters recede. We're pulling from expert plans, the latest research, real-world stuff, to give you that really holistic picture.
And I think what's really essential to grasp here, it isn't just about memorizing some checklist of actions.
Right.
It's more about seeing this intricate dance, really, between the pathogens, the people involved, and their suddenly altered surroundings. Which brings up a really important question, doesn't it?
Yeah.
Why are floods such a perfect storm? I mean, why are they so uniquely primed for disease transmission in the first place?
Okay, yeah, let's unpack that. Because for anyone working in public health, that epidemiological triad, the agent, the host, the environment, it's like foundational knowledge.
It is textbook stuff, almost.
But here's where it gets really compelling with floods. A flood doesn't just, introduce new threats. It fundamentally warps and accelerates every single one of those components.
Yeah.
Sometimes in ways we don't fully expect.
Exactly. It turbocharges the whole system.
So let's start there. How does the agent, the bug itself, behave when disaster strikes? What changes?
Right. So the agent, obviously, that's a microorganism causing the disease. Could be a virus, bacteria, parasite, fungus.
The usual suspects.
The usual suspects, yeah. But in a disaster setting, it's not just about them being there. It's about their explosive proliferation and spread. Think about waterborne bacteria like Vibrio cholerae that causes cholera, or leptospira, which gives you leptospirosis.
Nasty stuff.
Really nasty. And they absolutely thrive in contaminated floodwaters, especially when water treatment systems are damaged or offline. Then you've got, say, respiratory viruses like measles or influenza that you can just sweep through crowded shelters where people are packed together.
Close quarters.
Exactly. And we can't forget vector-borne threats like malaria carried by mosquitoes breeding in stagnant water, or even fungal skin infections that just flourish in those constantly damp conditions. But the really insidious part, I think, isn't just that these agents multiply like crazy. It's how the chaotic post-flood environment itself, the specific chemical soup in the water, the temperature changes, even the lack of sunlight getting through muddy water can actually help these pathogens survive longer. Sometimes it even makes them more virulent.
Wow. So the environment actually boosts them.
In some cases, yeah. It makes controlling them much harder than just cleaning up.
Okay, so we've got these microscopic agents going wild. What about the human element? Us, the hosts. Floods don't just expose people to bugs. They seem to fundamentally mess with our defenses too.
That's a hugely crucial point. It's not just the obvious physical stuff, like injuries.
Right.
A key insight, I think, is how the cumulative psychological burden of a disaster, the chronic stress, the lack of sleep, it silently compromises the immune system.
The stress factor.
Definitely. It makes people susceptible to things they might normally fight off easily. Then add in physical injuries, scrapes, cuts from wading through debris. Those are open doors for infections like tetanus or even gangrene.
Direct entry points.
Direct entry. And we also see weakened immunity just from poor nutrition or maybe pre-existing illnesses flaring up. Critically, you often see gaps in vaccination coverage suddenly becoming a huge problem, like for measles.
Right. Routine vaccinations get disrupted.
They do. And behavior is massive, too. People walking in contaminated floodwaters out of necessity, or just the unavoidable close contact in crowded shelters. Think about how hard basic hygiene becomes. Lack of clean water, no soap risk goes way up.
Yeah, simple things become impossible.
And the displacement itself. You have populations mixing, people with different immunity levels suddenly crammed together. It's basically perfect conditions for rapid transmission.
Okay, agent multiplying, host defenses down, and finally the stage itself, the environment. What happens to our surroundings that turns them into, like, a breeding ground for all this? Because it's not just the floodwater itself, is it? It's the whole infrastructure taking a hit.
Absolutely, not just the water. The environment is, all those external factors
Yeah.
affecting both the agent and the host. And floods just fundamentally transform our surroundings into this high-risk landscape for disease.
How so specifically?
Well, contaminated water supplies are probably number one. Broken pipes, flooded septic tanks or latrines, maybe the chlorination system fails. That leads straight to outbreaks of cholera, typhoid, hepatitis A.
The classic waterborne diseases.
Classics, exactly. Then, as the water sits around or recedes, you get those stagnant pools. Perfect breeding grounds for mosquitoes. Hello, Damie. Hello, malaria.
Right. The vectors move in.
They do. And consider the healthcare system itself. It's often disrupted, collapsed even. That means delays in diagnosing people, delays in treatment, vaccination programs get paused. Plus, power outages or damaged roads can mean small clusters of disease just smolder undetected until they explode.
You lose that early detection capability.
You totally lose it, or it's severely hampered. Then there's overcrowding in shelters prime time for respiratory infections to spread like wildfire. Poor sanitation obviously encourages all the fecal-oral diseases like diarrheas.
It's a domino effect.
It really is. Vector control programs stop. Waste disposal breaks down, attracting flies and rodents. Even things like lack of sunlight in muddy water or cool, damp shelters means bacteria and viruses can survive longer than usual. The whole environment just becomes this massive catalyst, pushing agents towards vulnerable hosts much more efficiently.
Okay, so seeing this really interwoven web of risks, what does it actually mean for doing something about it? How do public health teams even begin to tackle these constantly shifting threats?
It really boils down to a meticulously planned, multi-phase approach. You can't just react, you have to anticipate.
Phases make sense. Let's start at the beginning. Phase 1, before the flood.
Precisely. Before those floodwaters even think about rising, preparedness is absolutely key. This whole phase is focused on minimizing the potential harm and setting up robust systems before the chaos hits. It makes all the difference later.
Okay, so the groundwork. Once that overarching strategy is clear, how do teams actually activate surveillance? What does that look like, on the ground?
Right, surveillance activation. It means scaling up what we call early warning, alert, and response systems, UORS, getting them fully operational across all the potentially flood-prone districts.
Getting the sensors out there, basically.
Kind of, yeah. You're distributing standardized reporting tools, could be paper forms, could be digital apps to every single health post, clinic, hospital. And importantly, running refresher trainings for health workers on how to spot key syndromes, how to report rapidly, how to enter the data correctly.
Training is key.
Crucial. It's also about setting clear alert thresholds. Like if you suddenly see a spike above X number of cases of acute respiratory infection or Y number of diarrheal cases, that triggers an immediate alert. And holding daily situation reports, sit reps bringing together public health, clinical teams, logistics people, everyone needs to be on the same page from the start.
Makes sense. Constant communication.
And this phase also, critically, involves using tools like GIS, Geographic Information Systems, to map out not just the flood-prone areas, but also where specific diseases are already endemic. And just as importantly, identifying who the most vulnerable groups are likely to be pregnant women, maybe people on dialysis, young kids, the elderly, disabled individuals. You need to know where to focus resources first.
Targeted approach. Okay, beyond general surveillance, the next step must be anticipating specific types of diseases. How do teams prepare for something like, say, airborne illnesses, acute respiratory infections, ARI, pneumonia, things that can spread fast in shelters?
Yeah, good question. For those airborne threats, the pre-disaster focus is on defining really clear case definitions and identifying the priority syndromes you expect to see in a flood context, like what exactly counts as a suspected case.
Got it. Standard definitions.
Exactly. Then, physically pre-positioning rapid diagnostic kits, if available, and essential supplies like oxygen right at the planned shelter locations. Training clinicians specifically on triage protocols for respiratory illness and those early warning signs.
Triage becomes critical in chaos.
Absolutely. And setting up strict isolation areas in advance within evacuation centers, what we sometimes call hot zones for suspected infectious cases and cold zones for others, and ensuring there's reliable backup power for critical equipment like oxygen concentrators. You can't have those failings.
No kidding.
Right.
What about prevention levels you mentioned?
Right, so primary prevention is stuff like planning for good ventilation in shelters. Easier said than done, but crucial. Promoting mask use, cough etiquette, having masks and hygiene kits ready to distribute immediately.
Basics. but vital.
Totally. Secondary prevention is about that rapid screening, checking for cough, fever, shortness of breath as people arrive at shelters, setting up those isolation areas quickly, and deploying mobile health teams who can actively look for cases.
Proactive searching.
And tertiary prevention, that's ensuring immediate access to treatment antibiotics, antivirals if appropriate, definitely oxygen therapy, and having clear pathways for referring severe cases to hospitals that are still functional. The big challenge, of course, is doing all this effectively in incredibly difficult, often overcrowded conditions.
Yeah, I can only imagine trying to manage isolation zones in a crowded school gym.
Huh?
Okay, moving from airborne, how do teams tackle the, well, equally prevalent challenge of food and waterborne diseases, FWBD and zoonoses, those ones that jump from animals?
Right. For FWBD and zoonoses, the prep involves meticulous mapping. Identifying high-risk water points, places where people might come into contact with livestock or rodents, even before deploying teams.
Knowing the hotspots?
Exactly. Stockpiling the essentials. Oral rehydration salts, ORS, is huge for diarrhea. Broad-spectrum antibiotics. Chlorine tablets or generators for water purification. Water testing kits.
The toolkit.
The toolkit. And a really innovative aspect here is training what are called One Health response team.
One Health, tell me more.
Yeah, it's this approach recognizing that human health, animal health, and environmental health are all interconnected. So these teams combine human health experts and veterinary experts. They train together on outbreak investigation protocols.
Interesting. Makes total sense in a disrupted environment.
It really does. They pre-position specific veterinary PPE sampling containers, ensure they have cold chain capacity for animal samples too. And they develop SOPs, standard operating procedures, for jointly detecting human and animal cases and transporting specimens. Because often an outbreak in animals is the first warning sign for humans, or vice versa.
That One Health approach feels like a critical evolution, doesn't it? Really gets how blurred the lines become.
It's absolutely vital in these settings.
Okay, so disease-specific prep is intense.
Mm.
Are there other sort of broader, proactive steps taken before the flood hits?
Oh, yes, absolutely. It's a multifaceted effort. You've got crucial infection prevention and control IPC training for all health workers. Not just the frontline doctors and nurses, but everyone involved.
Everyone plays a role.
Everyone. There's vector mapping, understanding which mosquitoes or rodents are already present and where. And importantly, targeted pre-flood vaccination campaigns in high-risk areas for things like measles, Hep A, tetanus, if feasible.
Getting ahead of the curve.
Trying to. Regular simulations and drills are also vital. You have to test the whole response system, stress test it, find the weak spots before a real disaster.
Practice makes perfect, or at least better.
Exactly. Clear risk communication is huge, preparing the public not just on what to do, but why certain measures are important. Stockpiling isn't just about drugs and bandages, it's about manpower too. Defining roles, ensuring people are trained, having rapid mobilization protocols ready, and even thinking about staff wellness, keeping the response teams resilient.
Can't forget the responders.
Definitely not. And then there's wash water, sanitation, hygiene. Working with communities beforehand to improve infrastructure where possible, educating people on safe water practices like boiling, filtering, chlorination, training local volunteers as health promoters. They're often the most trusted source of information.
Community engagement is key.
Foundational. And lastly, even thinking about skin diseases. Sounds minor, but they can become rampant. So mapping shelters known to have poor sanitation, stocking basic hygiene kits, soap, antiseptic, clean towels, and topical treatments like antifungal creams, educating communities on simple hygiene like keeping feet dry, maybe even procuring incredible detail.
Wow. The level of proactive detail is staggering. Okay, so the prep is done, then the worst happens. The waters are rising, chaos is kicking in. This is the acute response phase, days 0 to 5 maybe. What are the absolute critical priorities now?
Right, this is where those pre-laid plans need to activate instantly. During this acute phase, food and waterborne diseases often worsen very quickly, so the immediate focus is activating that rapid diagnostic testing and case reporting through eWars that you set up earlier.
Switching it on.
Flipping the switch. Ensuring people have access to safe drinking water that might mean distributing chlorine tablets for household use, setting up emergency water trucking, activating pre-positioned water filters, distributing those hygiene kits you stockpiled.
Getting supplies out fast.
Super fast. And crucially, setting up ORS corners, oral rehydration salt stations in shelters and clinics to manage dehydration cases immediately. Diarrheal diseases kill through dehydration, especially in kids. Alongside this, you need targeted risk communication, hammering home messages about boiling water, safe food handling, hand washing.
Constant reminders.
Constant. And depending on the specific situation and testing results, you might even initiate ring vaccination for something like hepatitis A around confirmed cases to stop it spreading further.
Okay, waterborne is priority one.
Sure.
What about airborne diseases? They were a big focus before, but what happens during the peak chaos when conditions are probably at their worst for transmission?
Yeah, it's about continuing that vigilance, ongoing syndromic screening, just checking for fever, cough, difficulty breathing at all places people gather, especially at the entry points to shelters.
Keep screening.
Keep screening, reinforcing those well-ventilated isolation areas you hopefully pre-planned. Critically, maintaining the cold chain for vaccines. Maybe you're still trying to run catch-up measles or pneumococcal campaigns amidst the chaos. Supplying masks where possible and just constantly reinforcing respiratory hygiene. Cover your cough, wash your hands. It's a relentless, continuous effort to try and contain outbreaks before they really take hold in those packed environments.
Relentless feels like the right word. Okay, beyond those immediate life-threatening bugs, what about skin infections? You mentioned prepping for them. Do they get addressed during the acute phase? They sound maybe lower priority, but I guess they can get bad fast?
They absolutely can, and they really impact morale and well-being, too. So yes, during the acute phase, response often involves organizing daily wound care clinics. Simple cleaning, antiseptic, clean dressings, distributing soap, clean clothing if available, maybe footwear.
Practical help.
Very practical. A big part is educating evacuees on basic foot hygiene, trying to keep skin folds dry, avoiding unnecessary contact with potentially contaminated water. Teams actively monitor for and treat secondary bacterial infections like impetigo or cellulitis, which can turn a simple rash into something serious.
These can escalate quickly.
They can. This might mean deploying mobile dermatology teams, if you have them, or at least ensuring primary care teams are equipped and trained. And again, ensuring access to clean water just for basic washing makes a huge difference. It's often overlooked, but really crucial for preventing complications and just maintaining some basic dignity.
Dignity is important, too. Okay, this raises another point. What about people who already had health problems like diabetes, asthma, heart conditions? Disasters don't pause those. How are they managed?
You're absolutely right. This is a critical area, often called NCD decompensation, non-communicable disease decompensation, where chronic conditions get worse due to the stress and disruption.
Right.
So teams work hard to identify and register known NCD patients as they arrive at shelters. The biggest immediate challenge is ensuring an uninterrupted supply of their chronic medications, insulin, blood pressure pills, inhalers. This requires serious logistical coordination beforehand.
Getting meds to people.
Exactly. Setting up point-of-care monitoring stations in shelters, simple finger prick glucose tests, blood pressure checks, training community health volunteers, maybe even other evacuees, to help support medication adherence and, importantly, recognize red flag warning signs if someone's condition is worsening.
Empowering the community.
Yes, and establishing clear referral linkages to the nearest functional clinics or hospitals for people who need more advanced management. It's essentially about maintaining that lifeline for people who were already managing complex health issues before the flood hit.
So, okay, during the flood itself, it really sounds like it's about rapid activation of all those pre-made plans, hitting hard on immediate hygiene and water safety, and trying to manage both the new infectious threats and people's existing health issues under just incredibly tough, dynamic conditions.
That sums it up pretty well. It's organized chaos management, really.
No, the immediate danger, the floodwaters might have peaked, maybe starting to recede, but the health challenges, as you said, are far from over. What happens next in the recovery phase, say, after day 5 onwards?
Yeah, the landscape of risk shifts again. As the immediate danger seems to pass and waters recede or stagnate, a major concern now shifts squarely onto vector-borne diseases, things like dengue, malaria. These notoriously thrive in all that stagnant water left behind.
The mosquito factor really kicks in now.
It really does. The breeding sites just explode.
So as the landscape changes, the threats change too. What's the strategy for tackling these vector-borne diseases that really emerge in the aftermath?
It starts with meticulous entomological surveillance. That means teams going out, inspecting and mapping where the remaining mosquito breeding sites are, monitoring the density of adult mosquitoes using special tools like ovitrax or light traps. You need to know where the enemy is concentrating.
Finding the hotspots again.
Finding the new hotspots. Then comes vector control. This usually involves targeted fogging, either thermal fogging or ULV, ultra-low volume spraying in high-risk zones, typically at dusk and dawn when the main vectors are most active. Applying WHO-approved larvicides to stagnant water bodies to kill the larvae before they hatch, and distributing long-lasting insecticidal nets, LLINs, especially to displaced families in temporary
A
shelter.
sack on multiple fronts.
Exactly. Kill the adults, kill the larvae, protect the people. Crucially, community engagement is vital here too. Mobilizing local volunteers for source reduction campaigns, basically. Cleanup drives to eliminate potential breeding sites like old tires, containers collecting water. Distributing easy-to-understand leaflets or posters on how to prevent mosquito bites using repellents, wearing long sleeves.
Getting everyone involved in cleanup.
Everyone has a role. For case management, clinics and health posts need to be on high alert, watching specifically for dengue warning signs, things like severe abdominal pain, any bleeding, persistent vomiting, and classic malaria symptoms like cyclical fevers, ensuring they have rapid diagnostic tests, RDTs, readily available, and the right anti-malarial drugs in stock.
So quick diagnosis and treatment.
Essential. And finally, surveillance and reporting doesn't stop. You need to keep tracking suspected and confirmed cases daily through EWARs. If the number of cases per week in a specific area crosses a preset alert threshold, it triggers an immediate focused response in that zone. It's really a race against the clock as those mosquito populations boom post-flood.
Wow, yeah, the mosquito fight sounds intense. And what's fascinating, you mentioned zoonosis, earlier diseases jumping from animals. Can new ones pop up in this phase too from the changed environment?
Yeah.
How is something like leptospirosis handled? That one sounds particularly nasty, linked to contaminated water and soil.
It is nasty, and yes, it often peaks in the weeks after floodwaters recede, when people are cleaning up or wading through contaminated mud and water. So for zoonoses, specifically leptospirosis, the strategies include, first, risk assessment and screening, identifying groups at high-risk cleanup crews, farmers returning to fields, people living in still damp areas, setting up screening stations maybe, checking febrile patients for specific symptoms like severe muscle pain, jaundice, kidney problems.
Looking for the signs.
Looking for the specific constellation of signs. Then there's prophylaxis and treatment. For very high-risk groups like organized cleanup crews, public health might recommend doxycycline prophylaxis, usually a 200 milligram dose once a week while the exposure risk is high. For people with symptoms, early treatment with appropriate antibiotics, often empirically before lab confirmation, is crucial because severe lepto can progress rapidly. And referring severe cases for hospital care, potentially dialysis.
Prevention for high risk, early treatment for others.
Exactly. Rodent control also becomes critical again because rodents shed the bacteria in their urine, contaminating the environment. So deploying traps and bait stations strategically around temporary housing and water sources, trying to seal up cracks where rodents might enter, managing waste properly to reduce food sources for them.
Get the rats.
Basically, yeah. Environmental hygiene is also key, coordinating with sanitation teams to clear remaining debris and drain contaminated water pockets where possible, promoting safe waste disposal. And finally, ongoing monitoring. Carefully logging all suspected and confirmed cases in EWARs, tracking antibiotic use, and reviewing patient outcomes weekly to see if the strategies are working.
Okay, another complex threat tackled, but you mentioned something even more maybe insidious and long-term. Environmental hazards like heavy metals potentially stirred up by the flood. How on earth do you even begin to address those, especially when the contamination might not be visible?
Ah, yes. This is truly a long-term challenge and requires significant foresight, often stretching years beyond the immediate flood response. For environmental hazards like heavy metals, the first step, often delayed until things stabilize a bit, is comprehensive environmental testing.
Testing the soil and water.
Exactly. Collecting soil and water samples systematically from flood-affected zones, paying special attention to areas near old industrial sites, mines, or areas with heavy agricultural runoff. Testing for specific contaminants like lead, mercury, arsenic, cadmium, using portable field kits where possible, but often relying on reference labs for confirmation.
Mapping the chemical risk.
Mapping the chemical hotspots, yes. Then comes exposure assessment. Identifying who might be most at risk, young children playing in contaminated soil, pregnant women, cleanup workers without adequate protection. This might involve biological monitoring, like conducting blood lead level screening in kids under 5 living in affected areas, or in adults showing symptoms consistent with heavy metal exposure.
Checking people directly.
Sometimes, yes, if the environmental tests show high levels. Remediation and cleanup is the next big step, but it's complex and expensive. It involves engaging municipal services or specialized teams to safely remove and dispose of contaminated sediments or soils. It also means providing clear guidelines for residents and workers on how to safely handle potentially contaminated materials and decontaminate themselves and their clothing.
Requires specialized knowledge and resources.
Definitely. Risk communication is vital throughout this. Issuing clear public advisories about avoiding contact with specific polluted water bodies or soil areas, distributing leaflets explaining the signs and symptoms of heavy metal poisoning, and telling people where to seek help if they're concerned.
Keeping people informed of hidden dangers.
And finally, and this is crucial for long-term recovery, long-term surveillance. This might mean establishing special cohort follow-up clinics for periodic health monitoring of exposed populations, especially focusing on things like neurodevelopment in children exposed to lead. And, importantly, integrating all these findings back into municipal planning, informing decisions about land use, future industrial siting, maybe even building codes. It's not just about the immediate health impact, it's about preventing future exposures and ensuring a healthier long-term environment for the community to rebuild in.
That long-term environmental piece is huge and probably often under-resourced after the immediate crisis fades. Okay, so we've gone through the phases, the specific diseases, but beyond those phase-specific actions, it sounds like there are some overarching strategies, things that kind of glue the whole response together, no matter the disease or the timeline.
That's absolutely right. There are definitely persistent pillars that apply across all disease categories and through all phases of the disaster.
What are those key?
Well, health education is fundamental, and it needs to be continuous. Consistently promoting basic hygiene, safe water use, how to avoid vectors like mosquitoes, the importance of vaccination, adapting the messages as the situation evolves.
Keeping the messaging going.
Constantly. Community-based surveillance is another huge one. Empowering local volunteers, community leaders, traditional healers maybe, to recognize warning signs, report unusual clusters of symptoms early. They are often the first line of detection, feet on the ground.
Using local knowledge.
Leveraging it, exactly. Intersectoral collaboration is just non-negotiable. Public health can't do it alone. It means coordinating super closely, constantly with the WH sector, water, sanitation, hygiene folks with disaster management agencies, veterinary services, back to that One Health idea, NGOs, community groups, holding regular, maybe quarterly joint meetings before any disaster hits, running intersectoral exercises. These are vital to make sure everyone knows their role and can work together smoothly when the pressure is on.
Building those relationships beforehand.
It's all about relationships and defined protocols. And finally, simulation exercises. You just have to conduct drills, tabletop exercises, functional drills, even full-scale simulations if possible, to test the entire outbreak response system before a flood occurs. Find the gaps, fix the communication breakdowns, build that muscle memory across all the agencies involved. Preparedness has to be treated as a continuous state, not just a plan sitting on a shelf.
Yeah, continuous state feels right. This whole deep dive has really laid bare just how incredibly interconnected everything is when disaster strikes.
Yeah.
And how a proactive, truly detailed practice plan can literally save countless lives. From the tiniest microbes to us humans, to the entire altered environment, every single element needs consideration, foresight, and this constant need to adapt.
What's truly striking, I think, is the sheer breadth of that foresight required. It isn't just about having doctors and nurses ready for the immediate medical needs. It's about anticipating all those complex ripple effects, the contamination, the displacement, the broken infrastructure, the vectors, the long-term toxins. It's about seeing the entire system, not just reacting to individual parts.
So what does all this mean for you listening? Well, maybe next time you hear news about a flood, you'll think beyond just the dramatic images of water and visible damage. Maybe you'll consider this unseen, intricate battle against disease that's happening simultaneously, and the incredible, often completely unsung, work of public health teams operating behind the scenes, trying to stay one step ahead.
And maybe this raises a final question for you to think about. Beyond the direct communicable diseases we've spent time discussing today, what other long-term, perhaps less obvious health challenges do you think communities might face, maybe years down the line, after a major flood? As they rebuild their lives, their homes, their environments, think about things like chronic stress, the lasting impact on mental health, maybe access to ongoing care for chronic conditions, or those lingering environmental toxins that might not show effects immediately but could impact health for generations to come. What else is lurking beneath the surface?